I'm really honored today to introduce our speaker for the event, Dr. Deanna Saylor. She's an assistant professor of neurology at the Johns Hopkins School of Medicine, but also the director of the Global Health Neurology Program at Johns Hopkins. She's currently based full-time in Lusaka, Zambia, where she helped start the country's first neurology training program and currently directs the program at the University Teaching Hospital and the University of Zambia School of Medicine. So the program has already graduated 7 neurologists who are the first practicing neurologists in the country. So without further ado, I'll hand it off right away to Dr. Deanna Saylor.
So much, Lahoud, and thank you to everyone for coming today and for the opportunity to share a little bit about global neurology with you. So I titled this Careers in Global Neurology or Global Neurology 101. I don't have any relevant disclosures for the talk. And what I thought I'd do is just sort of talk about global neurology in general, what it is, why there's a need for neurologists who work globally, then share my own story on how I got started and ended up in Zambia, and then talk a little bit about global neurology career models and how to get started in the field. And I'm hoping this only takes about 40 minutes or so that we'll have lots of time for discussion and questions and answers as well. So just starting off with why global neurology. I think that a lot of what we know about the global burden of neurologic disease comes from the Global Burden of Disease study. So this is a study that's repeated every few years, and it's usually published in the Lancet, and it looks at the global burden of over 300 different disorders. And the 2016 study found that when you group neurological disorders together, they're actually the leading cause of disability-adjusted life years and the second leading cause of mortality worldwide. And while overall, if you compare age-standardized incidence rates of neurological conditions from 1990, when the Global Burden of Disease study first started, to the most recent iterations, the overall age-standardized rates are decreasing. But when you look at the absolute numbers of people worldwide that these disorders impact, that absolute number continues to increase. And that's partly because it's a growing global population, so there are just more people that can be impacted, but also because the global population is aging, and a lot of neurological disorders tend to occur in older individuals. But what this study has also shown us is that the global burden of neurological disease is not evenly distributed, and about 3/4 of the burden is actually in low and middle income countries. And unfortunately, these same countries have the smallest neurological workforce to care for these patients. And so the short version of this is that the number of neurologists simply does not match the burden of neurological disease. And we can see these graphs here from the WHO Atlas of Country Resources for Neurological Disorders in 2017. And this graph is showing the median number of adult neurologists for every 100,000 people in a country based on the country income strata. And so you can see here that in high income countries, there's almost 5 neurologists for every 100,000 people. And then that number really exponentially falls off, so that low income and lower middle income countries have only 0.03 or 0.13 neurologists for every 100,000 people. And when we look at the same graph by world region, you can see again huge disparities. So in Europe, there's over 6.5 neurologists for every 100,000 people in the population. And when you look at the Southeast Asia region at 0.1 neurologists, and the African region at 0.04 neurologists for every 100,000 people, obviously there are many fewer neurologists to care for a population. Yet those are the same regions where the majority of the neurological disease burden resides. In the US, this number is more than 5 neurologists for every 100,000 people. And in Zambia, where I work, it's about 0.02 neurologists for every 100,000 people. And the other part of this is that there are very few neurology training programs in many low and middle income countries. And this is especially true in sub-Saharan Africa. And so this is an old map. Unfortunately, the WHO was not able to update this map in their 2017 atlas. But about, almost 20 years ago now, when you looked at the countries that had neurology training programs, which are in blue, and then looked at the countries that did not have neurology training programs, which are in pink, and then countries where there were no data and probably also where no training programs are in white, you can see again that especially in sub-Saharan Africa, but also in the Southeast Asian and Middle Eastern region, as well as some of South America, there were countries that didn't have any way to train neurologists. And so without training programs, this huge disparity in the number of neurologists per population is going to persist for some time. And so I really think it's this gap between this high burden of neurological disease and these few members of the neurological workforce. This is the gap that global neurology tries to fill. And you can see by these articles here that global neurology is increasingly being recognized as a viable career pathway for academic neurologists in the US as well as in other countries. And so it's really a growing but very young field, but one that people are recognizing. The American Academy of Neurology now has a global neurology section. The American Neurological Association has an international outreach community. And so there's just a growing recognition within academic neurology at large that you can be a global health specialist and a neurologist together. And so how I got started, I think, is sort of a long and winding story that actually takes me back to medical school at Johns Hopkins. I was a third-year medical student and met a Kenyan physician who'd come to do an elective at Hopkins and became friends with him. And in talking with him, just realized that my entire concept of medicine at that point had been Johns Hopkins. And that was not really how most of the US got its healthcare, let alone most of the world. At this point, I had never been to a low resource setting before. I'd only been out of the country twice to other high income countries. And I just realized that I wanted to understand what medicine was like in other parts of the world. I did not at all think that this would be the career path that I would choose. It just seemed like it was important to have that experience and have that understanding as I continued in my medical training. And so I was able to get on a plane and I flew to Kapsawar, Kenya. So Kapsawar is this small village in Western Kenya, right in the Great Rift Valley. As you can see, it's a beautiful area. It's a village of about 5,000 people. And this mission hospital there is the only hospital for a district of about 25,000 people that covers a large area. And so I did a general medicine elective there for 8 weeks. And I finished that elective and came back to Hopkins and thought, wow, that was more impactful than I had expected. In fact, I loved every part of that elective. And, I had seen need before. Certainly there are areas of Baltimore that have a lot of need, but I felt like I was seeing need on a different level and that I could contribute in a more meaningful way in a setting like that. And so I came back to my third year of medical school and just started thinking, well, maybe global neurology, global health is something that I want to do. But I also recognize that 8 weeks in a place, you're certainly still in the honeymoon part of being in that place. And before I made such a big decision of trying to kind of follow a career of global health-based work, I thought I needed a more longer-term experience so that I could see if it's really something that I liked and was passionate about. And so I was lucky enough to apply for and be awarded a Doris Duke International Clinical Research Fellowship. And I was able to take a year out between my third and fourth year of medical school and fly back to Kenya, and this time to Kisumu, Kenya, where I was working with Dr. Anna Claire Meyer, who was at UCSF at the time, is currently working for the Department of Defense, and also Dr. Judith Kwasa, who's one of the neurologists on faculty at Kenyatta Hospital in the University of Nairobi. And this time I was based in Kisumu, which is the second largest city in Kenya. But a lot of our work was out in the villages. And so we would go out during the week. We would stay in a cottage out in these villages. And this was our research setting. So we would pitch tents and have folding chairs and tables and cots. And this is where we would see our patients, often at health centers that were run by a nurse and may not have even had running water at that time. And so this was a longer term experience. I was in Kisumu with Anna Claire for almost a year and a half. And again, I really, really loved the experience. And so I came back to Hopkins to finish medical school, really determined to pursue global neurology in some form. And so I finished medical school, I started residency, and I was really lucky that in my PGY2 year, my first year of neurology training, I was introduced to Dr. Ned Sachter, who was then on faculty at Hopkins, and Dr. Maria Waywar, who's a professor of epidemiology at the Hopkins School of Public Health. And they had just received a big NIH grant to look at the impact of HIV subtype on neurological complications of HIV. And so I was lucky enough to get involved in this study as a second-year resident. I was able to design a small sub-study on peripheral neuropathy that we embedded within their larger study. I was able to go to Rakai for 2 weeks during my PGY2 year, for another 2 weeks during my PGY3 year, and then finally for 6 weeks during my PGY4 year. And it was really during that last trip, that 6-week trip where I had time in country. It was, I think, in February and March of my PGY4 year. So I was almost finished with residency. I was almost a fully fledged neurologist at that point. And I think that really gave me a different perspective on the experience. So I was doing a lot of teaching of healthcare providers, and I was seeing patients and diagnosing myasthenia gravis and cryptococcal meningitis. And it was really during that trip where I realized that I really loved research. I loved the research that we were doing. I thought it was important. I thought it would directly impact the patients that we were trying to help. But I also recognized that when we were gone, there was really no one with the expertise to see these complex neurological conditions that I was seeing, even in this rural village in Uganda. And so it was during that trip where I thought, gosh, if I had my way, what I would really love to do someday is go to a country with no neurologists or very few neurologists and help to start neurology training there and train neurologists to see these patients and provide that expertise locally. And so I came back to Hopkins to finish my residency, and I went to the AAN meeting that year. And I was lucky enough to meet Dr. Gretchen Verbeck. I see is on the call today. And I always say she's really the founder of global neurology from an academic neurology standpoint. She started working in Zambia and Malawi in the 1990s and has continued to work in those places since that time, and was really the first person to show that you could be a global neurologist and have an academic career. And then I also met Omar Siddiqui, who was on faculty at Beth Israel and had been working in Zambia for about 5 years at that time, primarily doing research on his K Award. And both of them had recognized the need for a neurology training program in Zambia. And when I got to meet them and told them about the interest I had in starting a training program somewhere, we decided to try to make this work. And so I was back at Hopkins doing my neuroinfectious disease, neuro-HIV fellowship, and I ended up writing the curriculum for a neurology residency in Zambia. And then I sent that to Omar, and Omar managed to shepherd it through the University of Zambia bureaucracy to get it approved. And then once we got it approved, I said, okay, if I can find funding, I'll come lead the program. Not really sure what that would look like, but it ended up coming through. I ended up getting a Fulbright Award from the State Department that funded me to go back to Zambia for 2 years and start the neurology training program. And so we sold our house and our cars. We packed up our belongings, and I think we had 8 suitcases. You can say I had 2 tiny kids who aren't so tiny anymore when we moved, and a very brave mother-in-law who agreed to fly with us and help us get settled. And so we packed up and we moved to Zambia. And I've been based at the University Teaching Hospital here for the past 4 years since that time. And so when I arrived in Zambia, there were a handful of expatriate neurologists here providing primarily outpatient neurological care, as well as an EEG lab and an EMG lab, but there was no inpatient neurology care in the entire country. And so we set to work developing the first inpatient neurology service, as well as a neurology residency program. So before I get into that, just a little bit of orientation on Zambia. Zambia is this country in red here in Southern Africa. It's a country of about 18 million people, of whom about 75% live on less than $1 a day. It has the 7th highest HIV prevalence in the world at about 12%. So if you just let that sink in, that means that about 1 out of every 8 people that you walk by on the streets has HIV. It also is one of the WHO high TB burden countries as well. And to counter both of these, it has about 1/3 the recommended number of doctors for its population. So again, these numbers here are quite old at this point, but the population continues to grow faster than the number of doctors. And so we really have many fewer doctors than what is recommended to deal with these two epidemics. And now we add COVID on top of that as well. And again, when I arrived, I made the 4th expatriate neurologist that was here full time. The other 3 were predominantly doing research, although there was also outpatient neurology. But we started these programs at the University Teaching Hospital, which is the largest hospital in Zambia. It has 1,655 official beds, but that doesn't include the extra beds that are stuck in the hallways or the aisles. And just to give you a sense, at Hopkins, we have about 1,150 beds. One of the other really big academic hospitals, Jackson Memorial Hospital in Miami, has about 1,550 beds. So this is really a very massive hospital. It serves as the national referral hospital. So most of the physician specialists in Zambia are based at this hospital, and patients are referred from all over the country for specialist care. And it's also the primary teaching hospital in Zambia. This is changing a bit in the past few years when they've started to decentralize training. But up until a few years ago, it was really the only hospital where you could do postgraduate training in Zambia. And again, when I arrived, there was no inpatient neurology service, so neurology patients were cared for on internal medicine services and sort of scattered throughout the internal medicine wards. But we had most of what we needed to provide neurological care. So there are 2 CT scanners on our campus. Usually one of them is functional, although I say that, and both of ours have been non-functional since October, and we're having to ship patients across town in an ambulance to another government hospital to get CT scans, but we can get CT scans. We do have an MRI machine that's functional most of the time. Again, Dr. Siddiqui has set up an EEG lab, and Dr. Michelle Kavalson at the University of Rochester has set up an EMG and nerve conduction study lab. And then we have the capability to do lumbar puncture as well. Although this looks different, we don't have LP kits. We use usually IV cannulas as our spinal needles. And collect our CSF samples into blood sample tubes, and then our diagnostics are quite limited. So we can't get any viral PCRs. We essentially get the basic studies and a gram stain in culture. So these are just some pictures. These are the pictures of the medicine wards. You can see that we have 3 floors of medicine wards, and each one of these is pretty much a big open ward. There are a few small walls dividing it into subsegments, but in each one of these bays, there's about 8 or 10 beds of patients. And you can see here, this is one of those bays where you can see there's patients, and you'll notice that there are people next to each patient's bed. So these aren't patients, these are bedside caregivers. And their role is primarily to provide a lot of what we would consider to be nursing care in higher income settings. There may only be about 5 nurses for 50 or 60 patients on the ward. And so these bedside caregivers help to feed and bathe and turn and dress and toilet the patients as well. You can see there's not a lot of privacy. We have some sheets that we can pull down to at least examine the patient in some privacy, but it's hard to have conversations that are private here. And this is a typical picture on rounds where this is Machina Chamba, who is one of our first graduates when he was a resident. We often have a big group of students, internal medicine residents with us, sometimes visiting neurology residents from the US or other countries. And everything is done on paper. We don't have anything computerized in the hospital. And so there's definitely challenges. You know, we have very few diagnostic tests. We have very few therapeutics some days. Some days we don't have any seizure medicines, and some days we're even out of aspirin. And so we often feel like we don't have the right tools for the situation. And some days you feel like you're fighting an ostrich with a plastic chair. But through it all, we persist. And I always say that even if we can't do everything, there's always something that we can do to improve the care for our patients. And so along with implementing the inpatient neurology service, I think the thing that I'm most proud of so far is developing a neurology training program in Zambia. And I think it's worthwhile just stopping to think for a minute on why it's important to train neurologists in their home countries. And I think there's several reasons for this. And so the first is that when people train in their home countries, they're training on the disorders that they're most likely to see in their setting. So obviously the disorders that I saw most commonly when I was a resident at Hopkins are quite different than the disorders we see every day in Zambia. And so training people, again, in their home countries means they get to train with the disorders they're going to see most commonly, and also with the resources that are most commonly available. And so when you train in the country where you're going to practice, then you learn how to practice within the resource constraints that exist. And then also a lower likelihood of brain drain, meaning that if someone trains abroad, there's a higher risk that they'll continue to practice abroad and not go back and practice in their home country. Whereas if they're training in their home country and that's where their training is recognized, then they're more likely to stay and practice there. And so this is a picture of our first group of neurology trainees. So we have in the middle here Infama Kawatu and Lisa Nkole, who were our first pediatric neurology trainees. And then Stanley Zimba, Lorraine Chishimba, and Mashina Chamba, who are our first adult neurology trainees. And we started neurology training on October 1st of 2018. I think starting a program was really, really exciting for a lot of reasons. And one of them was that I was designing a residency program from scratch in a place where there had never been neurology training before. And so there weren't necessarily any preconceived notions about what neurology training was supposed to look like. So this offered the opportunity to me to think about my own training and what parts I really liked and what I wish I had been different, and try to create a program that reflected that. In addition, I was also able to blend the strengths of traditional Zambian postgraduate training with traditional US postgraduate training. And I think the first thing to mention is that postgraduate training in Zambia is optional. So not everyone does postgraduate training. Everyone will do a 2-year internship in which they have to spend 6 months doing pediatrics, 6 months in internal medicine, 6 months in surgery, and 6 months in OB. And then they're assigned a 2-year rural posting where they go out to a remote healthcare center, and they're usually the only provider at that healthcare center and have to be able to do the basics in all 4 of those disciplines. And at the end of that, they can continue to practice as a general practitioner, or they can come back and do postgraduate training. And postgraduate training in Zambia is actually a master's degree program. And so we had to design formal courses and formally assess our residents with different types of examinations. And as a result of this being a master's degree program, in most postgraduate training programs in Zambia, there's a very heavy emphasis on didactic learning and book learning and protected time for lectures. And that was one thing in my training where I felt like oftentimes lectures were sort of not protected, and you were often engaged in other clinical care activities and didn't get the benefit of actually sitting down and listening to the noon conference lecture. And so I wanted to maintain that protection of lecture time, didactic learning. But I think one of the things that I valued most in my training at Hopkins was this heavy emphasis on clinical bedside teaching and clinical decision-making. And that's something that is not necessarily emphasized in all Zambian postgraduate training programs. And so I really wanted to blend the two together. The other thing to note is that our program followed the structure of other internal medicine subspecialty programs that had been approved in Zambia. Excuse me. So neurology is still considered a subspecialty of internal medicine in Zambia. We're still housed within the Department of Medicine. And so our residents do 3 years of either internal medicine or pediatrics training, and then they do 2 years of either adult neurology or pediatric neurology training. So it's a 5-year program with just 2 years of neurology. The other thing that I really wanted to do was to intentionally create an academic and research focus within the program. And so I was really aware that we were essentially creating a new field of medicine within Zambia. You know, there had never really been practicing neurologists. There had never been Zambian neurologists. And so as we were creating this in-person patient service and expanding access to specialty neurological care in the country, I wanted our trainees and our graduates to, if they were interested, have the skills and the knowledge and the ability to pursue independent research that generated really locally relevant data that could then be used to improve our systems of care, to improve our advocacy efforts with the Ministry of Health and other policy experts, to really try to improve neurology care within Zambia. And so to do that, I built in a weekly journal club, a weekly research methods seminars, and then encouraging scholarly activity into our program. And our trainees have really just accepted this challenge and run with it, and have made oral and poster presentations at multiple national, regional, and international neurology meetings, which has been really exciting. And I think the other unanticipated benefit that I didn't appreciate when I was designing the program was what I like to call a spillover effect. And essentially what this means is that there had never really been a neurology team in the hospital that was consistently seeing patients and teaching, every day. And there had never been a neurology service that the internal medicine residents could rotate on and get a lot of exposure to neurology all at once. And so when we started just having a daily presence at the hospital, seeing more patients, teaching more people, we saw the general neurology knowledge of the non-neurology trainees really start to improve. And when you look at that from a public health perspective, if we train 2 or 3 or 4 neurologists every year, it's going to take generations before we have enough neurologists to meet the demand for neurologists within Zambia. But if we can improve the general neurology knowledge of all the graduating medical students and all the internal medicine physicians who can then competently care for the common things, the stroke and epilepsy and headache, then that's going to make a huge difference at a population level. And so it's been really fun to see the medicine residents really start to improve their neurology knowledge and care as well. So this is just a picture of our celebration at the end of our first year of training. And then I always say the proudest day of my professional life when we birthed 6 Zambian neurologists. And so along the way, Melody Asukile, who started her training in Cape Town and came and finished the last 6 months with us because of COVID, joined us. And so a little over a year ago, we graduated our first 6 neurologists, and we've had another Moses Mata just graduated this past year as well. So we're now up to 7 Zambian neurologists. And I think, thinking about the future and sustainability, we're on track to train 13 adult, and it should now actually be 3 pediatric neurologists in the first 5 years of the program. Our first 6 graduates are all serving as junior faculty within the program. Our 7th graduate is the clinical director of a level 1 hospital within Lusaka and is bringing neurology to that hospital. And, we're really starting to see our impact grow. And I think the most exciting thing for me is that our graduates are still involved in the program and taking on greater and greater leadership roles within the program. And so, when our time is done here, then I know that it will be in great hands and will be a self-sustaining program without the need for any expatriate support as well. And so that's sort of my pathway to how I ended up giving you this talk from Lusaka today. And I think just in thinking through how I ended up here, how I've seen colleagues navigate their career, I thought that we could just talk a little bit about what career pathways in global neurology look like. And I really think there are several different models, and no one model is going to work for everyone. And so I've sort of organized these on the kind of lightest commitment to the greatest commitment. And so one possibility for involving global neurology in your career is, doing short-term clinical visits to contribute to others' programs. And so there are lots of examples of this. Mike Rubenstein at Penn has a clinic in Tanzania that he's worked with, I think, for maybe 15 or 20 years. And he takes a group of neurology residents and medical students there twice a year. They spend a month there seeing lots and lots of patients. And, he has patients that he's been following every 6 months for years and years now. And so doing these sort of shorter term visits, especially when they're paired with one site where you continue to collaborate and develop relationships with, is an option. We often, at least pre-COVID, had attending neurologists and visiting neurology residents at our program in Zambia who contributed to the teaching and training of our residents. And so I think that's one possibility. Another possibility is building research collaborations in an international setting. And so developing collaborations with local investigators on the ground, and you travel to the site 1, 2, 3, 4 times a year, but really the local investigators are spearheading the projects and making the day-to-day efforts work and leading the projects. And so building these sort of distant research collaborations, especially over time, as you, again, partner with the same group over and over again and get to know them and build those relationships, can also be a viable way to be involved in global neurology. And then finally, there's working full-time in a global health setting. And this can be either in a research capacity or in a clinical and capacity building capacity. And I think this is probably the most rare model, but in sort of the one that requires the greatest commitment as well. And so I think the reality of this is that one size does not fit all. And I think it's also important to note that what fits now may not be what fits in 5 years, and what you're doing now may not be what you're doing 5 years from now. So, I've been in Zambia for 4 years. We anticipate being here full time for another 5 years or so. And then we're not sure after that. And then I envision that at some point in my career, I'll be back in the US the majority of the time, but we'll sort of revert to this number 2 model, where the relationships that I built during my time in Zambia and the collaborations that we built will continue. And I'll still always have some sort of presence in Zambia, but will not be full-time in Zambia forever. And so I think it's just important to think through as you're thinking about your family circumstances or your job circumstances and wondering what that looks like. It's just to remember that whatever career path or model you're looking at may not be the same as what you're going to be looking at in the future. And there's flexibility to go back and forth between these models as well. I can also wanted to direct you to this paper that was published a few years ago in Seminars of Neurology. I had the pleasure of writing with Nicolene Schiess, who's done a lot of work in the UAE and now works for the WHO, and Joe Zunt, who's done a lot of work in Peru on neurocysticercosis and other topics. And this is sort of an outline of different types of career pathways, as well as how to fund those career pathways and think about making them work, especially within academic neurology. And so I think, how do you get started? I think the first thing is to either pick a region or pick a problem. And what I mean by that is that there may be a particular part of the world that you are connected to. Maybe your family's from that, maybe there's something that kind of draws you to that part of the world. And so it may be more important to you to dedicate part of your career, your time, to contributing in a particular world region than to choose a particular problem or base it on the local epidemiology. So that's one option. Another would be to say, I'm really interested in neuro-HIV, which was my case. And so I'd like to go to sub-Saharan Africa, where I'm most likely to see neurological complications of HIV. And so again, kind of picking a region or picking a problem that really motivates your interest in global neurology. And then you've heard me say kind of over and over, emphasize the importance of establishing relationships. I think it's really important that once you pick a place and you find that it's a good fit for you, that you keep going back to the same place over and over and over again, that you think of this professional relationship just like any other relationship in your life, that it takes time to develop and it takes time to build trust and it takes time to really understand the other person. And so really dedicating yourself to building a strong relationship with the people that you're going to be working with at that site. And then I think the other really important and essential aspect is when you go to the site, remember that you're going as the learner and not the solution giver. You can't walk into a place that you've never been before and know how to solve all the problems. The reality is that you probably don't really even understand what the problems actually are, and certainly don't understand how to solve them or the limitations to the solutions that you think are viable. And so really making sure that when you're going, your posture is one of a learner, that you're going to be learning from the experts who are the people on the ground at that site who work in that site every day. And then, over time, as you build that relationship and understand that site and the both the strengths and limitations of that site, then you can partner in being a solution generator with your on-site partners as well. And I think also important to find a mentor. And so I mentioned earlier that global neurology is a relatively young field, and also means we're a relatively small field. And so when you are looking for a mentor, I think reaching out to any of us who do global neurology and telling us more about your interests, and if we're not the right person to mentor you, it's likely that we can point you to the right person who can mentor you as well. And I think a mentor is particularly important because global neurology is such a new field. There are fewer kind of well-worn, tried and true paths on how to make a career work. And so it does take an experienced mentor to sort of guide you through that. I also want to just kind of stop and acknowledge the fact that the whole term global neurology is a bit of a loaded and colonialist term, I would say. I think the true definition of global neurology is just practicing neurology outside of your home country. But I think in practice, it's often used to refer to practicing neurology in a resource-limited setting. So there are many people who are practicing, quote, global neurology every day in their home country, right? And so I think it's important to kind of acknowledge that. And I think that these starting points are still applicable to people who are coming from a low resource setting. I think that establishing collaborations within your home country, but also with international partners, either from higher resource settings that may have more access to resources or funding to help you build a research program or a clinical program, but also the importance of establishing regional partnerships where you can really leverage the experience and expertise of your regional partners to build on more than what you can just do at your own site is important. And so I think these are still applicable even if you are based primarily in your home country, which is a low resource setting. And I think the importance of a mentor also can't be overstated for anyone who's junior in neurology, and really finding a mentor who can guide you as far as opportunities and funding and how to face challenges. And so I think going back to picking a place to build a partnership, you really want to make sure that you have a point person on the ground in that place and someone who's going to provide the level of support that you need. And so I think especially if you're going to do a clinical experience, practicing outside of your level of experience in a foreign healthcare system is not good for you or the patients. And so this is particularly true for medical students and residents who are going to go to an international setting for a rotation, is just making sure that you have adequate supervision and support. And the American Academy of Neurology website has a list of international sites and opportunities for medical students and residents that have been vetted and are a good starting place to try to identify opportunities. And then I think funding is the other big thing that the further along you get in your medical training, the more of an issue it becomes. And the reality is that for international collaborations of any kind, the bulk of funding that's available long-term is really for research. And so from a US perspective, if you think about the NIH, its mandate is really research. And so they fund research training programs, but they don't really fund clinical training programs. And it's hard to find opportunities to find funding to support the development of clinical training programs. And I think the exceptions are the award that I got that funded the first 2 years of my stay here, the Fulbright Scholar Award through the US State Department, which funds academic exchanges between the US and other countries. There's also a program called Seed Global Health, which is focused on building clinical care and training within multiple different low and middle income countries. They typically focus more on sort of the primary areas of medicine, your family practice physicians, internal medicine, pediatricians, OBs, that sort of thing. So they don't typically fund neurologists, but in my conversations with them, they would be open to considering that. And so that's another thing to explore. If your passion is really medical education and training and clinical program building, these are the types of things the types of funding opportunities that you could consider. And then finally, there are religious missions organizations who fund people to be based full-time and really provide clinical care and education. There are also a few smaller awards for education research as well. But I think the take home here is that really, if you're considering an academic global neurology career and you want it to be sustainable and you want it to make up a large portion of your career, you're really going to need to be doing some type of research in order to stay funded and have the opportunity to continue to do that work. Again, I wanted to make sure that we're not just going to focus on US neurologists. So this slide is for US neurologists, but my next one will be thinking more about non-US based neurologists. So if you are a US neurologist, what are some global health specific opportunities? I think the first is that your home institution may have institutional awards that you can use. The ANA has an International Outreach Award. The World Federation of Neurology has grants and aids. The Royal Society of Tropical Medicine and Hygiene has seed grants. And then the NIH does offer a 5-year career development award called the International Research Scientist Development Award that funds you to be based in your host country for the entirety of the award. There's also opportunities that are not specific to global health, but that will fund international work. And these are multiple opportunities through the AAN as well as R25 awards during residency. And then later on, most NIH funds can be used to fund international work if it's relevant to US populations as well. And then there are some that are specified specifically for international collaborations, primarily through the Fogarty Center. And then if you're a non-US based neurologist, there are opportunities as well. So again, the ANA, the World Federation of Neurology, and RSTMH are all opportunities for smaller grants. The NIH also has Fogarty Fellowships that are 1-year research development awards. And the Fogarty also has a K43 Career Development Award that's for international junior scientists. It's a 5-year award. And so those are all opportunities. And again, these kind of more generic NIH awards can usually be repurposed if you have a US-based collaborator as well. So that's what I had for you today. I have a lot of people to acknowledge as far as especially our Zambia neurology trainees, lots of different funders who've supported my work in Zambia and Uganda. And then just want to highlight two really big stars in global neurology who left us too soon. So on the left is Kevin Robertson. He was a neuropsychologist who did a lot of pioneering work in HIV-associated neurocognitive disorders in Africa. And Ned Sachter, who is my primary mentor at Hopkins, also did a lot of the HIV work in Africa. Both of them died too soon from cancer. And so we just want to recognize them and all of their efforts and certainly their contributions to my own career. And so with that, I will wrap up. I'm happy to take any questions. Please also feel free to jot down my email address. I'm happy to answer anything via email as well. So thank you so much for your attention and the opportunity to speak, and look forward to your questions.